Hello, everybody. This is Johanna Ralston, and I'm CEO of the World Obesity Federation, and it's my great pleasure to welcome you today to the collision of two pandemics, COVID-19 and obesity. I did just get on, and thank you very much. I think if you can look at your screens, and in the lower left, there should be a small microphone that says mute, and please press that. We are having some issues with the centralized mute function today. Zoom is online trying to help us with this, but in the meantime, we really appreciate your help with us. I want to thank everybody who is joining us today. We've had extraordinary interest and support in this, and we are very much pleased to present really an all-star group of experts who are going to describe where we are in obesity and COVID-19. Initially, I'm going to tell you a bit about housekeeping rules. Again, please mute yourselves unless speaking. The mute button should be at the lower left of your screen if you're on Zoom. If you're on your phones, generally *6 should work. But thank you very much for your help with this. You can use the chat box, thank you very much, to post comments and questions if preferred. We do have already over close to 1,000 people on, so we are going to distill comments to the best of our ability, but we will also be following up and responding to comments. There will be a chance to ask questions later, and now the agenda for the session today. The first part of the agenda is around setting the stage with our board president, Donna Ryan, and then we'll be going into science and evidence behind the association between COVID-19 and obesity, of which there is quite a bit of evidence and new evidence emerging in the midst of this crisis. Then issues affecting patients with obesity from Karine Clément, lessons from early respondents from our colleague Su Lim in Korea, collision of the two pandemics in South America, where the pandemic is still in our earlier phases of the curve from Dr. Ala Cuevas, and then summary and takeaways. Next slide. So it's now my great pleasure to turn over to Donna Ryan, President of World Obesity Federation, who will be setting the stage.
Thank you very much, Johanna, and thanks everyone for attending today. I know many of you are familiar with this dashboard. It gets more than 1 billion hits every day, and it's probably the best and most reliable resource for seeing what's going on globally with the COVID-19 pandemic. So this is sponsored by Johns Hopkins University Medicine, and it is a dashboard that gives a running tally of what's going on globally with COVID-19. So unfortunately, we have passed the 1 million mark late yesterday in terms of number of total confirmed cases. One of the good things about this dashboard is that you not only can get a visual tracking of where cases are, confirmed cases are occurring, and what's showing on this screenshot is the cumulative confirmed cases, but you can also see over on the left what's going on in countries, and this is really tallied by number of confirmed cases, and the US is currently leading in number of confirmed COVID-19 cases. But you can also track active cases with the tab on the bottom. And then you can also see over on the right, the total deaths. And I'm sad to report that we have more than 50,000 deaths currently. But we also track on this dashboard the total recovered cases, now 217,000. If you look at the tabs on the bottom, you can look at not just the cumulative confirmed cases, but you can also track the daily increases. So I recommend this website for everyone. It is a sobering view of what we are dealing with the pandemic of COVID-19. Now we know that risk for serious complications of COVID-19 is related to underlying conditions, and many of those underlying conditions are related to obesity. So I'd like now to ask Johanna to make some comments about background on COVID-19 and the World Health Organization. Johanna?
Thank you very much. I'm speaking on this a little bit because we were due to have a participant from the World Health Organization, and unfortunately, the dynamic environment there, they were at the not able to join. Again, for panelists, I think we may still need to ask you to mute using the button on the lower left corner of your screens for Zoom. So thank you very much for that. We are still working on this issue. So just as to again set the stage and the work with WHO, on December 31st, as we were all, I think, hoping that 2020 would be perhaps a less challenging year than 2019 had been, the WHO received information from China about an outbreak of pneumonia of unknown cause detected in Wuhan City in the Hubei province in China. And again, as of April 2nd, as of yesterday, the number of cases has now surpassed 1 million. And earlier this month, this was declared a pandemic by WHO. The WHO, because of the correlation between non-communicable diseases, NCDs, and COVID-19, and particularly the particular risks associated with it, they have issued this statement. For people living with or affected by non-communicable diseases, people of all ages can be infected by new coronavirus, COVID-19. The risk of becoming severely ill with the virus appears to increase if you are 60 plus. People with pre-existing NCDs appear to be more vulnerable to becoming severely ill with the virus. These NCDs include cardiovascular disease, CVD, again, people who are at risk or already have experienced a heart attack or stroke, hypertension, and other types of CVD, chronic respiratory disease, including chronic obstructive pulmonary disease, diabetes, and cancer. In this case, so just to set the stage, obesity is not a separate independent risk factor at this point, although we are going to hear today about, in fact, the level to which obesity is being seen in serious cases of COVID-19. And the other piece is data in general is not systematically collected about BMI, which would help to understand this picture better. So what we are working with is a mix of anecdotal and sort of collected data. The World Obesity Federation, which is a close partner to World Health Organization and official relations, does believe that part of this is obesity is both a disease and a risk factor, and as such has not been identified as not being captured in terms of evidence in a systematic way in terms of the 5x5, the 5 main NCDs or 5 main risk factors. We can provide more information about that, and you can find more on the WHO website. However, we know that our colleagues at WHO are very certainly aware of and concerned about the correlation of obesity and COVID-19, and hope that this becomes an opportunity to again encourage the systematic collection of BMI where possible. We will now go to the next slide, and our first speaker, it's my great privilege to introduce Dr. Stephen Heimsfeld from the Pennington Biomedical Research Center and immediate past president of the Obesity Society in the United States. Thank you, Stephen.
Thank you, Joanna. The first 7 cases that came to autopsy in New Orleans, Louisiana, where I'm a resident of the state, 5 of those people had severe obesity, 2 of them BMIs over 40. So the question comes up, what is the evidence for COVID-19 complications being at increased risk in patients with obesity? And as a background, I'm sure you're all aware that comorbidity risks are increased in patients with obesity. For example, type 2 diabetes has an odds ratio of over 7 in people with severe obesity. And many people with obesity have multiple comorbidities, not just one. Dyslipidemias, type 2 diabetes, asthma, obstructive sleep apnea, all are common in patients with obesity. Moreover, there's evidence in the past that people with obesity have increased susceptibility to viral infections. They often have a chronic meta-inflammation state that has systemic implications for immunity. delayed and blunted antiviral responses to influenza virus infection. There's a vast literature on viral infections in patients with obesity. Most of the evidence suggesting that they're increased risk, that they do less well with these conditions than patients without obesity. Given that as a background, the CDC is beginning to report, Center for Disease Control in the US is beginning to report the epidemiology of people infected with coronavirus. And in one report, very recent report, they reported that patients who were infected with coronavirus but not hospitalized, about 1/4 of them had a single health condition, a comorbidity of some type. By contrast, 71% of those who were admitted to the hospital but not in the intensive care unit had a single health condition. And people admitted to the intensive care unit, 78% of them had a single health condition, indicating that having a comorbidity of some type is a major risk factor for not only hospital admission, but ICU admission. And the CDC reported that type 2 diabetes, chronic lung disease, cardiovascular disease are the common comorbidities, all of which are, as you know, common in patients with obesity. 94% of the deaths that they analyzed had at least one health condition. And some of the other risk factors, as you know, are older age and male sex. But even after you exclude those, obesity seems to be a common thread that runs through these other comorbidities. Now, if we go to the next slide, we're beginning to see some early clinical observations, and there are probably even more since I made the slide a day ago. But New England Journal, JAMA, and other Lancet, other major journals are publishing these reports coming out very quickly. But some of the first reports came out of Seattle, 2 publications in New England Journal of Medicine. The first 24 patients with coronavirus admitted to the intensive care unit. The BMI reported in that group was 33, well into the obese range. 51% of those patients had type 2 diabetes, 21% obstructive sleep apnea. And as Joanna mentioned, it's very common for obesity to be put on the background, and the comorbidities like type 2 diabetes being the main diseases reported. Obviously, many of those patients with type 2 diabetes are also obese. Now, of those 24 patients, half of them died over the short term, so the mortality rate was very high. In the second study, a long-term care facility had coronavirus infection, 167 cases, including the workers at the center, and 22% of them were obese, and about another 22 or 23% had type 2 diabetes. And we can only guess that the type 2 diabetes and obesity overlap with each other. And another large report coming out of UK from Intensive Care Network, 795 ICU admissions. Critically ill patients with BMIs in that study mirrored the general population in early viral pneumonias, supporting that idea that obesity is not an increased risk factor for coronavirus infection, but the data is still very early. In the case series reported by Marzo from Italy, there were 3,200 deaths. 1/3 of those patients had type 2 diabetes. Another approximately 1/3 had cardiovascular disease, and 48.6% of those with 3 more comorbidities also reported deaths. And notably in that series, they found that obesity was a lethal risk factor in those young patients who developed coronavirus. And I think if we take these findings collectively, we see that we need more data on susceptibility and outcome information on patients with obesity. It's still very early. Now, if we go to the next slide, there are some special considerations for patients with obesity that put them at increased risk. For one, at least in the United States, severe obesity is present in almost 10% of Americans. They are notably at increased risk if they get infected. Many patients with obesity obviously have underlying chronic comorbidities, which in itself is a risk factor for coronavirus. Heart failure, high blood pressure, non-alcoholic steatohepatitis, hypoventilation syndrome, and patients with obesity are at increased risk of developing acute respiratory distress syndrome independent of the coronavirus. Often intubation and extubation are difficult. Central IV lines insertions are very difficult in patients with severe obesity. They're at increased risk of thromboembolic events, pressure ulcers, and other related events in ICUs. Many scanners, such as MRI scanners, CT scanners, have size limitations, and those important diagnostic tools in this case. And also, many medical units and ICUs are not designed to accommodate patients with severe obesity. Notably, beds are not activated enough to raise the back of the head and so on to avoid pressure from extreme fat on the respiratory system. And I think there's still, having said all of that, there's still a question about whether or not patients with obesity are at increased risk of ICU mortality. There's still an open question, but that gives you a little bit of an idea of where we stand as of today, and this can change at any time. Happy to answer any questions. Thank you.
Great.
Thank you very much for that.
Let's move along
Okay.
to the next slide. And our next speaker, Corinne Clément, who is from Paris and is going to talk to us about issues infecting patients with obesity and COVID-19. Corinne?
Yes, thanks a lot, Donna and Joanna. So I'm here in Paris, and just to tell you that we recently reviewed the situation in France, and thanks to the combined work of several associations, the French Association for the Study of Obesity and the Association for French Nutrition Association. So if we go to the next slide. So basically, I would like to come back to other medical issues which affect patients with obesity. And as mentioned by Steve in the first part of the presentation, as you may know, I mean, there's no data yet about whether or not a patient with obesity would have an increased infection risk. But while working with the French Association for the Study of Obesity, basically we review the situation for other viral infection. And there are indeed data suggesting that in obese person, there is a greater severity risk. And the data come from hospitalization rate. And there has been, for example, a very interesting study in Mexico showing that indeed when you have a BMI over 30, the risk is over 8 to go to the hospital, and it can reach 35 when you have severe obesity. And this was done for the H1N1 infection. And for other type of virus, other type of coronavirus, not COVID-19, because we don't have the numbers now, the risk was nearly 3. And it's not only an increase in hospitalization rates, but also in intensive care unit. And a colleague from France basically performed a meta-analysis on that, and it was more than 3,000 subjects looking at mostly H1N1 infection. And again, it seemed that having obesity, and especially severe obesity with body mass index over 30, increase the risk of hospitalization in ICU, as well as the risk of death. So it seems that we need to be aware about that, and probably we need the numbers now from the different ICUs And I'm sure that in the coming weeks or so, days or weeks, we will have this information. But there are other issues, and what we need to be aware, and this has medical implication. First, again, looking at the literature for other viral infection, it seems that the response to antiviral and antimicrobials is poorer in obesity. So basically, obese person have difficulties it's difficult to answer to this and be controlled with these antiviral drugs. And it includes also the response to vaccine. And what was showed in some review is that persons with obesity have a poor sustained seroconversion. So of course, for now, we don't have a vaccine for COVID-19, but that will be some things probably to take into account if we look at other type of infection. And again, we need to be aware about that. Another quite remarkable and interesting issue was about virus shedding. Indeed, it seems, again, from reporting data, especially for influenza A, is that patients with obesity have had about more than 40% longer virus shed than non-obese person. And this is not only true for people being symptomatic, but also for people being asymptomatic and post-symptomatic. So again, you know, many people now in the world have to stay home and avoid, contamination between each other. And I think we need to be careful again. And we need some awareness about that for COVID-19 in subjects with obesity. And again, probably in the future, we will have information about virus shedding, future vaccine, and so on. Now, if we go to the next slide, again, as you have heard, and we learned a lot from data coming from China, as well as also from Italy, there is a major risk of acute respiratory distress syndrome in obesity. And you can see on the slide the set of severity risk factors, including hypertension, type 2 diabetes, COPD, impaired kidney and liver function, low-grade inflammation, as well as elevated dyslipidemia. So Steve alluded to that a little bit, and I think there are some specific awareness again in the context of obesity and severe obesity. And probably when we usually think about severe obesity, but probably we'll have also data from people having more common obesity. But there are issues about restrictive respiratory failure, alveolar hyperventilation. I would like to come back on the thromboembolic risk. It seems, and there are more and more data about the impact on the virus on pulmonary embolism. And as you know, and this was mentioned, in person with obesity, there is increased thromboembolic risk. So again, this needs to be taken into account, and probably to adapt also the treatment and using anticoagulant drugs in this person. Then there is immune frailty in obesity, and this could explain also the data I just mentioned for other virus and the risk in obese person. As you may know, that there is an altered balance between anti-inflammatory and pro-inflammatory factors in the context of obesity and low-grade inflammation. And if we go a little bit more, there is altered functionality of T lymphocytes. And again, some data from China just came out showing that the virus, the COVID-19 virus, had a major impact on the T lymphocytes and on their functional activity. So again, we learn probably from future studies, but we can't think about obese person who already have alteration in the functionality of T lymphocytes. So that's something that probably we will need to understand better in the future. And
So
again,
Corinne,
yeah.
There's one question that has come in that maybe you can address. What about viral shedding and BMI data in patients who are asymptomatic? Is there any data out on this yet?
Yeah, there are. So in the paper I was mentioning, so it was done in Nicaragua, and actually, and this was evaluated from people households for several seasons, and it was done for H1N1 virus. And basically, yes, there was increase the virus shedding by more than 100%. For this type of virus. So that's something we need to know, and for COVID-19, because of course we don't know for now. Okay, and regarding the other medical issue, I think something also we need to take into account, which is probably also very important in the context of persons with severe obesity, is the nutrition problem. So this patient under this acute infection may develop malnutrition, and sometimes the diagnosis is delayed. And it's important to keep in mind that it can also be true for obese person. And finally, there is controversial results for this acute respiratory distress syndrome and the risk of mortality in obesity. And again, looking back in the literature, basically, it's true that in terms of mechanical ventilation, there is increased time of mechanical ventilation in obese person, as well as the duration of stay in intensive care unit. But we will need numbers specific for obesity in this context for the COVID-19. So, yeah, so there's a lot to learn from that, and we absolutely need to get information from the different hospital setting as well as intensive care unit to get a clear idea about what's going on for people with obesity. Thank you.
Thank you. Karine, this is Johanna. Thank you. I just want to, first of all, thank you for answering some of the questions as you went. Just a reminder, there's more than 1,000 people on this call, so we are capturing your questions. They're excellent. We will be taking them up at the end of this, towards the end of the presentation, but we will also be housing this presentation on our website, and you can access it there later. So thanks very much, and
thank you.
So next speaker.
Okay. So I think we can learn things from countries who were first in the path of this virus. So let's move on to our next speaker, who is Sue Lim from Korea. So Sue Lim, what lessons can we learn from your experience with the coronavirus pandemic?
Yes, I'm very happy to be here. Today I'm here to share our experience with you. So today I'm going to introduce current status of COVID-19 in South Korea, followed by our measures, which I believe was effective and can be implemented in other countries if it is possible. Let me start my presentation with the first slide. Since the first case of COVID-19 identified on January 20 this year in South Korea, the number of cases rapidly increased, as shown here, resulting in 10,000 cases as of today. The outbreak in the southeastern part of Korean Peninsula, which accounts for more than 80% of Korea's COVID-19 cases, appears to have been mostly brought under control as of now. In contrast, new cases in Seoul and its surrounding area account for a large part of the current number. Next slide, please. May I have, yes. In terms of the severity of COVID-19, the fatality rate increases with age in Korea, as shown here at the bottom level. It is obvious that fatality is high in patients with chronic diseases such as diabetes, coronary heart disease, or renal impairment, as the previous two doctors already mentioned that, I think that people with obesity are also at higher risk of COVID-19 because obesity is commonly associated with decreased immune function. May I have next slide, please? Fortunately, in general, the COVID-19 infection seems to be under control gradually in South Korea, and more importantly, mortality rate is quite low in Korea. In no way are we the best at it, but I can definitely say several factors for this low mortality rate. So firstly, early detection. To detect infected people ASAP, South Korea set up test stations all across the country, which makes testing quick and effective. You can even find drive-through test stations like Starbucks or McDonald's, where you don't even need to get out of your car to be tested. Secondly, aggressive and widespread testing. Right from the start, Korea government was producing hundreds of thousands of test kits every single day. To this end, Korea has continued to test as many people as possible. Thirdly, previous lessons. We had experiences with SARS and MERS, which have better equipped us to deal with this current crisis. Lastly, the rapid measures. In South Korea, the infected patient steps were retraced. People they came into contact with were able to be identified and tested. In addition to this, the places they went to were also cleaned, sanitized, and if necessary, closed. Because of these factors and these strategies, COVID-19 seems to be under control in South Korea, and due to this, the factors or this effort, daily life, business, and economy were able to continue in a relatively normal way without any lockdowns in South Korea. At the last part of my presentation, I would like to suggest a couple of measures or strategies. Before introducing that, I would like to summarize the presentation briefly. COVID-19 is a global pandemic, and it may pose considerable health hazards, especially for people with chronic disease such as diabetes or heart disease. Virus infection could be risky for people with obesity because their immune system is commonly more easily compromised. Close monitoring of people with obesity required because of less physical activities and unhealthy food consumption under the pressure of social distancing. So to combat this COVID-19, we have adopted several measures in South Korea. So the COVID-19 epidemic changes our daily life in South Korea. So most fitness centers are closed, which is mandatory. And more people use Korea's efficient delivery system to receive food. Obviously, they commonly order pizza, burgers, and fast food. In this situation, doing exercise, consuming healthy food are very difficult. These factors contributed to more weight gain in people with obesity. In terms of reducing the risk of COVID-19 in people with obesity, measures need to be taken by both the individual as well as the healthcare professionals to ensure that they stay healthy and reduce their risk. It is always true that prevention is better than treatment. So I would like to suggest using technology to our advantage, like YouTube's home training videos, or a virtual reality or VR system, or interactive video games particularly for children with obesity, can be used as a tool to stay active and to fight boredom in these difficult times. We do not want to let fears for this virus cripple us. Normal life, I believe normal life can continue pretty much as before. as long as we take precautions, such as wearing a mask, washing hands thoroughly, and keeping social distancing. This is what I have. Thank you for your listening.
Excellent. Thank you.
Thank you very much, Sue Lim. Let's move on to our next speaker, and that is Ada Cuevas. So Ada, what are the implications and potential challenges for the collision of the two pandemics in South America? And I think what we can learn from you is really lessons for other low and middle income countries. Ada?
Mute.
So I don't think we have Ada on the line yet. So
no, I am in the line.
okay, good.
Okay.
Thank you.
Hello to everybody. Thanks for the invitation. Next slide, please. Next slide. Can you hear me?
Yes.
Yes, we can hear you. So,
Yeah, everybody know that worldwide obesity has nearly tripled since 1975. And as you can see in the right side of the screen, South America is not an exception to this problem, mainly in developing countries in South America. So this increase in obesity in South America has been associated to its related comorbidities, such as type 2 diabetes, high blood pressure, cardiovascular diseases, between others. But the problem is that the epidemic of obesity in South America is coexisting with another malnutrition problem, that is undernutrition, affecting mainly to low-income regions of South America. So in this mixed and complex scenario, we know that an unexpected and severe new enemy and a new pandemic disease has emerged all over the world, including South America. Everybody knows we are talking about that, COVID-19. So COVID-19 pandemic has required a number of measures taken by most of the countries, including in South America. Unfortunately, not all of them, including quarantine, social distancing, a strained food system, indoor activities, and closure of schools and universities. Next slide. So what will be the consequence of COVID-19 and all these measures in South America? Well, certainly our life have changed. We have changes in our diet. We are increasing more processed and long life food. We are taking less healthier and fresh foods like fruits, vegetables. And also we are taking the option of delivery of food at our home that usually are fast food. Moreover, we have a social distancing, like a school closures that our children are having classes at home. We are working at home, and we are doing many other activities at home, like this webinar. That is very important, but we are having a sedentary lifestyle. Also, the other consequence is an impact in our mental health. All of us, we are with stress, with anxiety, mood disturbance. We are worried. So this problem make us more nervous and produce some problem with our sleep. We are sleeping less. And also we have higher appetite, mainly for special foods. mainly caloric food like sweets, and also it has been observed and a higher increase in alcoholic beverage. Also, we have changes in our time activities. We are going to sleep late. Probably the young people is waking up late. Our meals times are different. So all these changes may create some disturbance in our circadian rhythms. And also it's possible that all this alteration, and in addition maybe by the infection per se, can induce some disturbance in our microbiome. So all these factors are very well-known risk factors for obesity and for its related comorbidities, with the consequent increase in health costs. But the problem that we will have, in addition, the consequence of the COVID-19 impact in economical aspect, health aspect, mental, physical aspect, and many other things. And it will be worse, unfortunately, in low-income regions. The next slide, please. So what are our challenges for the collision of the two pandemics in South America? Very, very, very important challenge. During the COVID pandemic, immediate challenges are try to maintain nutritional food for most of the people, mainly for those more vulnerable like diabetics, older peoples, pregnant women, facilities to do physical activities, indoor physical activities, psychological support, and in this aspect, facilities for telemedicine have a key role. And after the COVID-19 pandemic, that all we expect will be a not so long time, we have very important challenge for everybody, for governments, health authority, education authorities. They have a challenge for improved sanitization, immunization, food healthy supplies, mainly in low-income regions. And also we have challenges for a struggle with the pandemic of obesity, improve healthcare system, practice for obesity care, prevention and treatment policies. Also, we have to increase and improve educational training in obesity for healthcare professionals. And for us, for the healthcare provider, it's very important that recognize obesity as a chronic disease that deserves an early diagnosis and appropriate treatment, and of course, a follow-up of our patients. For food industry, big challenge. They have to invest in the development of healthy, non-expensive, and sustainable foods. For workplaces, very important challenge. It's important to promote and provide facilities for healthy work environment. And for all of us, not just for South America, for all the world, for the general population, we have to take a message after this terrible situation that we are living. In the future, in the near future, we have to adopt permanent healthy lifestyle, promote breastfeeding, protect our environment. And if you have a problem, please ask for help for your community and for your healthcare professionals. Next slide that I want to finish. I want to share with you this beautiful sentence. The suns always shine after the storm, but it's very important that we must work together. And in the right side, you can see sun appear after the storm in the southern part of South America, Torres del Paine in my country. Thank you very much.
Thank you, Ada. That was excellent. I think Donna is now going to. We have a number of questions, and so Donna is going to take those questions and direct those to different speakers.
Yeah. So thank you very much. You know, we're getting lots of questions about asking for slides and asking if this seminar is going to be available after the webinar is over. And the answer is yes. So we will certainly be making available this webinar on demand after we finish today. And we'll also put downloadable slides up on our World Obesity Federation website so that individuals who don't have access to the webinar in the future can download the slides and use them for their purposes. We're also getting questions about psychological impacts on patients with obesity, on what to do with bariatric surgery patients who are having their procedures postponed. And I want to let everyone know that there will be 2 additional webinars, one next Thursday and an additional one the following week. The next webinar will really be focusing on patient issues, and the last webinar, 2 weeks from today, will deal with childhood obesity and the COVID epidemic. So stay tuned for those, and we won't be answering those questions. But there was a good question that just came across that I'm going to submit to Corrine, and that is, what about ACE inhibitors and angiotensin receptor blockers? Should we be stopping these in our patients with obesity?
Yes, thank you. Yeah, thanks, Donna. That's indeed a question that just came up several times also in the webinar we made in France. So basically, there has been a discussion on that because the virus is attacking the RAS system, the renin-angiotensinogen system. And, you know, some groups were thinking that using ACE and IRB would be an issue. However, either Cardiovascular Hypertension Society make a clear statement for now, is the fact that people don't have to stop, and it's not recommended to withdraw from antihypertensive drugs in general, because the adverse effect would be worse. And so now it's clear that all these societies mentioned that this treatment shouldn't be continued. So there is a pathophysiological issue. There are questions, but it also could be that these drugs actually have a positive effect rather than a negative effect. And there is a study now which is going on in the US with losartan, and we'll see what's going on, the outcome of this study. So to be clear, the patient shouldn't stop treatment.
Very, very good. So don't stop the ACE inhibitors and ARBs. And I think that this is an area that really needs to be investigated.
This is
Please
so
go
I'd
ahead.
like to add one comment.
Okay.
The concern about using RAS inhibitors in patients with this coronavirus comes from the AC2, because there are some data showing subsequent downregulation of angiotensin converting enzyme 2, but not all RAS inhibitors affect AC2. Some of them affect, and some of the others don't. So we don't know yet the effect of AC2 degradation. So we have to wait and see. So before we get the final or the compound the data, we have to continue RAS inhibitors to our patient.
Thank you, Sue. You know, I'm also seeing a lot of questions that are really mechanistic. You know, so this association between obesity and COVID-19 complications, that appears to be emerging from the data. But the mechanisms behind that, I'm getting questions about, is it all due to hyperinsulinemia, for example? And I think we need to understand that when the dust settles, we may be able to do research to answer those questions. But for right now, I don't think we have complete answers to that. I think it's so important that we do research in this area. And, you know, it's difficult to do research during these times when the demands of clinical care are so great. So, but afterwards, I think we'll be able to go in and look more carefully at mechanisms. And I think we're just going to have to be patient about answers to that question. So what I want to do now is summarize what we've said so far. And then I hope that I'd like to go around to our panelists and ask them for their final comments. So what we've been hearing is that it appears that patients with obesity have an increased risk for COVID-19 complications. And the evidence is coming out to support that more and more clearly. And it appears that patients with obesity are likely to have increased viral shedding and also are less likely to respond well to immunization. And the evidence and the proof of that will probably come with our future studies. Also, my takeaway was that from lessons from around the world were that there are no quick fixes and that we need to, this is not something that we can conquer overnight. And the lesson from Korea may be that continued community spread is going to occur because of this shedding, viral shedding from asymptomatic individuals. And so in the future, that is going to be something that we'll be more and more concerned about, and especially the implications for patients with obesity and that viral shedding. It was clear from Ada's comments that South America is challenged in ways that high-income countries are not. Our low and middle-income countries are challenged due to not just the virus, but also to the disruption in providing the basic human needs in those countries. So what are we to do? Let me go around to our panelists and what takeaways would you like to give us? Steve, why don't you start?
Okay, first I want to make a comment, and that is
Please do.
what we're seeing when you look closely at the literature is that obesity is often given a back burner. The focus is on type 2 diabetes, asthma, obstructive sleep disorders, and so on. So I think it's very important that we try and separate out and understand the independent effect of obesity on this disease. And we need to collect the data. We need to get weights and heights and other basic information. But at the same time, it's very important that we continue to practice social distancing, hand washing. We need to keep our nutrition up, as in our patients as well, our physical activity level, get good sleep, and maintain our interpersonal relations with people so we don't become depressed. Those are my thoughts, Donna.
That's great, Steve. And I want to applaud your request for research in the connection between obesity and COVID-19. You know, the journal Obesity, the official journal of your society, TOS, has a call out for papers to help us understand this. So now let's move on to Corinne. Corinne, what are your final remarks?
Yes, thank you, Donna. So we spoke about drugs. So I would like to come back about that. As we said, we patients need to continue their anti-hypertensive drug. And there was another question about anti-inflammatory drugs, and especially ibuprofen. I think unless it is a basic treatment for a chronic disease, a chronic pathology, I think it is not recommended for now to take this anti-inflammatory medication, probably because of the impact on especially ibuprofen. Again, I think we will get new information in the future, and there are more and more data coming back on especially the inflammation burst that's occurring during the COVID-19 infection. And that's probably one recommendation. In other terms, if you have a fever and flu, just use paracetamol, but not ibuprofen, which is very important. And the additional very rapid statement, because this was linked to a question about very rapid weight loss. Probably during this phase, it might be not recommended to have a rapid weight loss, and people under bariatric surgery need to have a close follow-up.
Thank you, Corinne. Sue Lim, please give us some final advice.
Okay, so I would like to say that the central to all of this is a common mindset. So this is not a problem happening to only one country. This is really the global problem. So this is a problem that we all face, and the only way we can beat this problem is by working together. In times like this, we need each other more than ever. So that it is why it is vital to help each other, help your neighbors, and help people around you to keep good and healthy lifestyles. Spread the good words, try to educate and be considerate of others. All of your actions have result, so think before you act, and act in a way that does not put yourself over anyone else. So if we are to beat this, we'll need each other. That's my final remarks.
Sue Lim, thank you very much. Ada, please give us some final comments.
Yes, I absolutely agree. We will have difficult times in South America, but not only in South America, in all over the world. And the most important is that we have to help each other, and we have to work together. And a simple message for everybody. This is, I think that I want to be positive. I think after this terrible situation that all are living, we will be enlarged. We will have more power, and we will learn. We have to learn the message. I think that we have to enjoy simple things, just to walk outside. The parents should be learned to have meals with their family, enjoy the simple things, adopt a healthy lifestyle for all the time. And the young people need to learn that outdoor activities are very fun. Yeah, so we have an important message. And I think that we work together and help each to others.
Ada, thank you. My final word of advice is that we all need to learn more. We need to learn more about the relationship between obesity and COVID-19 so we can help our patients. And one way to do that is to attend the next 2 webinars that we're having. Now I'd like to turn this over to Johanna.
I thank you very much, everybody. I want to really thank all of our panelists, fantastic group of experts for very diverse and relevant presentations, and also the more than 1,000 people who have been on the call, many of whom I want to echo are from the Gulf region, Asia, Latin America. Very, very interesting, really fascinating set of questions, which we'll do our best to try to consolidate and respond to as well. This will be on our website, and again, the next session is focused on the patient, and also on activities and techniques for people with obesity, who are sheltering in place. And that's next Thursday at the same time. It's 1 p.m. British summertime. And then Friday, the 17th of April, we will have a focus on children, both from the prevention and the management perspective. And again, we have a similarly diverse and very exciting group of speakers. We have additional resources on our own website. Please do go there. And then I want to commend our colleagues from the European Association for the Study of Obesity and Obesity Society, who also have excellent resources available. And again, our colleagues around the world with World Health Organization and the NCD community and others, nutrition colleagues, all putting together fantastic information, which we're supporting. And I guess just one final word is, this is a time where I think we're seeing how relevant and central the complex disease and risk factor of obesity is. And if we can, really take, hopefully this will elevate understanding of this, and as Steve said, measurement and capturing data around it, so that we can continue to strengthen our ability to address it. Thanks very much on behalf of everyone at the World Obesity Federation and our colleagues and members and partners all over the world. Thanks very much, and we'll see you next Thursday.